abuse and mental health service administration, bringing recovery support to scale technical assistance center strategy, otherwise known as brass tacks. Our TA Center is dedicated to increasing access to recovery supports, and we achieve this work through a variety of mechanisms, including a lot of TA focused on systems transformation and developing the capacity of peer-run recovery community and family and youth-led organizations. My name is Jonathan Cox, and I'm a Senior Associate with the Center for Social Innovation. Today, we'll be talking about recovery housing. We're very fortunate to have three amazing presenters with us who will be talking about their own experiences. I'm pleased to introduce today's presenters, Jason Howell, President and CEO of Recovery People, and a founding member of the National Alliance of Recovery Residences, NAR. Trina Fearson, President and CEO of Mending Hearts, Inc., and Sharon Fitzgerald, Senior Director of Housing and Recovery Support Services at Central City Concern. I'll be turning things over to them shortly, but first, we'd like to hear a bit from you. As people were arriving today, we posted a poll question for you all to answer, and I can see that a number of you have done so already. We seem to have a wide variety of people here, a number of recovery coaches and peer support specialists. 20% of you are working in recovery housing. A number of you are treatment service professionals. We have some homeless service providers, always good to see, supportive housing providers, and then some from the government, some social workers, and a number of other professions. The style of today's event is dependent on the participation from you. You'll see 3 more polls up in the room today, and we hope that you'll participate. This helps us better understand who's listening, what you're all thinking, and how we can respond to you as we move through the event. During this event, participants will be in listen-only mode, but we want to hear from you. Please share your questions and comments at any time during this event by typing into the box labeled "Post your comments and questions here." It may take us a bit of time to get to them, but we will do our best. Today's session, which is being recorded, will last approximately 1 hour. If, as you are listening to this content, you feel your organization may need technical assistance around this or any other topic, please visit our website after this event and click the Request Technical Assistance button to let us know what you need. Please listen in using your computer rather than using a phone line. If you experience audio difficulties, there's a phone number available in the audio instructions pod in the upper right of your screen. If you experience other technical difficulties, please request assistance in the chat box. Tech support staff are viewing comments and responding to your needs. When we close this room, a satisfaction survey will automatically open in your internet browser. We will appreciate you taking a few minutes to complete the survey, since your answers help us to better serve you. And with that, I'd like to get us started and turn this over to Jason. Jason.
Thank you so much. Can we go ahead and get poll 2 up, Melissa? And as John said, we really encourage you to participate in the polls. It gives everybody a sense of who's in the room and helps us kind of guide the conversation. My name is Jason Howell, and I'm a person in long-term recovery from both mental health and substance use issues. And I really got passionate around recovery housing in 2008. I'd gotten some recovery underneath my belt and looked around, and I really wanted to give back. And I was able to, see so many people learning how to live recovery in recovery housing, and that's the reason that I've been so passionate about it ever since. So I always like starting by going back to the basics and what is recovery? And we're really fortunate that SAMHSA developed a definition, a working definition back in 2011, 2012. And it's really, recovery is a journey. It's a process. And it's all, moving towards a self-directed life where we can have optimal health and wellness. And there's been, 4 supportive domains that have been identified. That's health, home, purpose, and community. And what I mean by health, that's learning how to manage your disease. And for someone like me, that's learning how to maintain my sobriety. Home is a safe and supportive place to live, a stable place to live. Purpose are those meaningful daily activities, and I mean that can be anything from from working, volunteering, going to school, being a caregiver, or even being creative, but giving meaning to our life. And then community, that's really important for recovery. It's those recovery-oriented, pro-social bonds that we develop with friends and people who support us in our recovery. I also want to frame today's conversation in the context of housing choice. If we really believe that recovery is a person-driven process, then we should support individuals in their housing choice. And I know today we're talking specifically about recovery housing. I wanted to acknowledge that there's a lot of other housing that we should have within a robust continuum of housing choices. And I definitely wanted to give a shout out to the other housing models out there in addition to recovery housing. So what is recovery housing? If I'm looking at some of your answers, and I probably some of y'all can answer that better than I can, but for those of you who are unfamiliar with recovery housing, for me it's sober, safe, peer supportive living environments we can trace back to the 1800s. And they're a proven way of supporting individuals learning to start and maintain their recovery. And they really can go by different names. There's a lot of variety in the types that are out there. I was really fortunate back in 2010 of joining a group of national thought leaders. I think there were people from 20 different states. And we were trying to have a productive conversation, but found that we were talking right past each other. And it's because the different terms out there that you may have heard, a sober house, halfway house, three-quarter house, different people use those in different ways. And so it became really important for us to develop a standardized nomenclature or language so that we could have meaningful conversations. Because if we that were working in the recovery field were having a challenge understanding, what's what, we definitely know that individuals that were trying to choose the right recovery home were having struggles as well. So with that, the National Alliance for Recovery Residences, or NAR, identified these 4 different types of recovery residences. And generally, when you hear people talk about recovery housing, they're talking about levels 1 and 2. But just to kind of give you perspective of all the different types that are out there, you can see that level 4 recovery residence is slightly less service intensive than acute care, which would be detox or inpatient residential. And then you go down to 3, 2, and 1. And I really want to point out that this is not meant to show that recovery is a linear process, because it's not. So an individual should be placed into the appropriate levels of support that they need at any given time. So someone can discharge from treatment and go down to a level 2 if that's what they choose and what's the best fit for them. If their symptoms exacerbate or say relapse, then they may want to step up to a level 3 or 4. It's important to have this rich continuum of choices so that we can cost effectively match individuals with the appropriate level of support. So this slide really shows one way that you can distinguish between the different types. It's looking at their service bundle. So in addition to housing, different recovery residences package different types of services. And you'll notice that all of them are based on social model recovery. It's a philosophy that really focuses on peer support, mutual aid. I call it the secret sauce in the recipe. If you are from the South, I call it's the roux in a good gumbo, because it's ubiquitous. It's throughout the community, and it's really about cultivating the community, empowering peer leadership and peer governance, all in a recovery supportive way. In addition to that, as you start moving up into these higher levels of support, you may find more formalized recovery support services That could be one-on-one recovery coaching. It could be recovery check-ins, or somebody that's facilitating a recovery exercise, a recovery group. And this is being facilitated by individuals who are trained and in some states, say certified to provide recovery support services. And then again, as you move up into the levels of support, you start seeing life skills development being offered, and in the highest level, clinical services as well. So the other way that you can distinguish between the different types of recovery residences is looking at their staffing and governance approach. So you'll notice that across all of them, remember in the previous slide we talked about the social model and it really highlighting the importance of peer support. So you can see that peers are utilized in all types of recovery residences. In a level 1, which I would say Oxford House is the iconic level 1 recovery residence. This is where individuals live together and support each other in recovery, and they democratically elect their leadership. So they'll democratically elect a house president, a house treasurer, etc. In a level 2, it's very similar to a level 1, but rather than democratically electing the house president, there is a senior resident or house manager that is appointed, but serves in a similar role as a house president. And then as we move up into 3s and 4s, it's a much more robust staffing model. Remember, these levels are providing a lot more services, and so we need to staff it appropriately, but not lose that social model, not lose the peer support. In 3s and 4s, you'll see individuals that are trained, certified, and ideally supervised. So I can't talk about recovery housing without talking about some of the major barriers. I think that one of the biggest barriers to growing the capacity of recovery housing is fair housing discrimination. Oftentimes we are seeing municipalities, cities, counties, and in some cases states that are creating ordinances or passing laws that are really pushing individuals out of recovery housing or are forcing them out of particular neighborhoods. You may have heard NIMBY, not in my backyard. That's closely related with this. So how we are a protected class as an individual in recovery, I meet the civil rights definition of disabled. So a city couldn't regulate my housing based on my disability any more than they could regulate housing specifically based on the color of my skin or what church I would go to. Now, I also wanted to point out that fair housing rights don't extend to individuals who are using illicit drugs or engaged in criminal activities or really a threat to themselves, others, or property. And that's true for anybody in any protected class, including persons with disabilities. So I want to spend a little bit more time unpacking this because people start scratching their head. If you've dealt a lot with SSDI, they utilize a specific definition of disabled, which is intentionally very narrow. And it's about qualifying individuals for certain funding streams. And it explicitly excludes individuals, or you cannot be eligible for SSDI solely based on the fact that you have a substance use disorder. That's very different than the civil rights definition of disabled, which is intentionally very, very broad. And it explicitly includes individuals who are in recovery from substance use. And I think the other big barrier to recovery housing is around funding. So, big surprise, right? Looking at what are the primary funding mechanisms for recovery housing, it really depends on what level of support we're talking about, in addition to what population you're serving and really kind of where you're located in the United States. So with level 1s, Oxford House, and level 2s, which you may have heard as sober livings or recovery homes, those are primarily self-pay. So the operational cost of a level 1 or 2 is such that individuals can work and pay rent, and that recovery residence is generally sustainable with that revenue model and business model. You can imagine that as we start adding, different, more staffing and additional services, that the operational costs go up, and oftentimes people can't afford the level of support that they actually need. So on this slide, I also listed some other examples of revenue streams. So to the extent that NAR levels 3s and 4s are licensed treatment within their particular state, they oftentimes can access the same insurance payment mechanisms that other licensed treatment programs can. And some interesting things are happening. In California in particular, they've started using some of their Medicaid 1115 waivers to pay for level 2 recovery residences. In addition to that, there's really, we can spend an entire hour just talking about the opportunity for more federal dollars, state dollars, and local government dollars to be utilized for recovery housing. I think some of the standouts in the United States right now is Ohio. And I saw Aaron from Ohio. There might be some other people on today's call that are from Ohio. The state of Ohio allocated over $10 million to recovery housing. And in local areas, you'll find jail diversion programs or maybe some particular funding that's linked to a particular population, say women and children, that can also be accessed by recovery housing. So with that, I appreciate the opportunity to talk to you about one of my favorite topics today. And with that, I'll turn it back over to you, John.
Thanks, Jason. I appreciate that. Okay, so let's take a look at poll number 2. What brought you here today? And again, we've got a pretty varied set of answers. So 30% of you are treatment professionals and want to know more about recovery housing. Another 35% of you are gathering general information about recovery housing. A few of you are interested in starting a program. Some of you are more immersed in homeless services and want to learn more about recovery housing. And then we've got some people who are working or managing a recovery housing site. Okay, we can go ahead and put the third poll up. And while we're doing that, Sharon, Trina, I'd be interested to hear what you think. What's one key point you'd like people to take away from Jason's PowerPoint? Perhaps if you'd like to go first, Sharon, and then Trina can join in as well.
Sure. Thank you, John. I'm Sharon Fitzgerald. I'm also a person in long-term recovery who accessed recovery housing as part of my journey. I'm glad that all of you are here. I think it's really that piece about choice. There's a long path of recovery, right? And so it's really this idea that people change throughout their recovery, and they sometimes are moving forward and sometimes moving maybe a little bit backwards and then back forwards again. And so this different level of housing types with different levels of services. And then I think in the bigger context about just choice in general around housing that we've been saying, that if you're in recovery and you're seeking housing, it makes sense maybe for you to live in recovery housing, but we need to have options also for people that maybe are not at that point in their life and ready to change and able to, access housing with maybe lower barriers to it. So I think that was the piece that really spoke to me about the PowerPoint.
Interesting. Trina.
Good afternoon. Thank you. Jason, good job. You are definitely a great advocate for family members in recovery. I'm Sabrina Priors, the CEO of Mending Hearts, a program that I founded through the passion of being in recovery, and I too am in long-term recovery. I think what spoke to me most, again, is the ability to have agents of change in recovery, particularly to the housing model. And Jason did a great job in specifying what levels of care really mean and how you can disciple through which level of care could benefit the particular participant. I like the fact that he was clear about funding is a challenge, but there's opportunities for different levels of care. I love the fact that we have a representation from NAR that we can get information, and there's a lot of data and information on SAMHSA as well. But I think that, funding recovery housing and starting a recovery housing, I think it's a lot simpler than it was when we started, Jason. I think people have more resources that you can reach out and grab. And so what really spoke to me about Jason's presentation is that we even have codes that we don't have to be subject to on because I live next door to someone who's in a better financial status than I do. I can open my home in my community no matter where I live. And so I think taking some of that stigma off is a great resource. Thank you for that information, Jason.
Thanks, Trina. Jason, before we move on, perhaps you can clear up a question that one of the participants has asked about one of your slides around sexual orientation.
So yeah, I was typing in the chat box. I don't remember saying anything about sexual orientation, but I possibly could have, because I do believe that recovery housing for special populations, underserved populations, is really important. Most recovery housing is gender specific, and then from a sexual orientation standpoint, in 2008, my first recovery home was specifically for gay and bisexual men. It was the only LGBT-specific home in Texas at the time, and one of the few in the United States. And so I'm glad that you brought that up, and we should be looking for funding mechanisms that would allow us to open housing for these underserved populations.
Thanks, Jason. Okay, let's take a look at the answers of poll 3. And I can see that slightly less variety than some of them. Over almost half of you have said that you primarily fund your recovery housing through self-pay. There's some of you that use state funds, a few of you that use federal and local funds, and then some of you that say all of the above. We totally understand that. So I'd like to go back to one of the points that Jason made, and someone's asked a question about that. You elect leaders in some of your recovery housing. Tell me more about that, all of you, and and in particular, how does peer support work in recovery housing?
Well, I'll start. One of the defining elements or characteristics of a level 1 recovery residence is that leadership is democratically elected, so yeah, it's just like you would think. If the residents are living in the house, it doesn't matter whether you live there 1 day or 10 years. You have a vote, and it really Oxford houses and level 1s are really fantastic for individuals that are at a place in their recovery that they can really own a lot of that, and it helps to kind of develop a lot of great skill sets. In the higher levels of support, you may have a designated house manager, but still it's important to cultivate leadership within the house. This is not a us versus them dynamic. You develop a culture where this is our house, and we've chosen to live by these rules, and we support each other in recovery.
I'll just piggyback a little bit off of Jason, if I could. Having that culture of community in the first level 1 and 2 has really been effective, where the members themselves become peer support advisors and within their own counseling sessions of just making sure that they're advocating in not a clinical setting, but really advocating with the other peers so that they become stronger within their own community, and they become passionate about, their own recovery in order to reach back and help others. And I think it's a great leadership tool that has come about, allowing peers to participate in their housing community.
Is Sharon on mute?
You couldn't hear me? Sorry. Can you hear me now?
Yay!
Sorry. So Central City Concern isn't operating recovery homes, like single-family homes, but we do a lot of recovery housing within the affordable housing projects that we own and operate. And we have close to 900 employees, close to 50% who identify as in recovery. So we have sort of the traditional recovery mentor, peer specialists working within those projects, but we also are employing people coming out of our projects. So we have, everywhere from the janitor to the front desk clerk to the case managers, the peers, all the way up, through leadership, including myself, that identify as in recovery and are really having an impact on how those programs operate. And as someone who went through like Oxford House, I know that kind of self-governing, I mean, it teaches you a lot of things around boundaries and how to have leadership roles and work as a team. And so I have just seen over the years that, I think the traditional clinical workers, maybe that I don't identify in recovery, are a big part of the treatment, but the peer support goes a really long way for people to be able to identify with others that they're working with.
Thank you, all three of you. So we've had a question about MAT, or medication-assisted treatment. Would one of you please just give a general explanation about what that actually means? And perhaps talk about why most recovery houses don't accept clients on medication-assisted treatment, and is that likely to change?
I'll take a stab at it. I think this is one of the most important questions currently in recovery housing. I mean, we've got the backdrop of an opiate epidemic, and really trying to understand, so how do we support individuals who are struggling with opiate use disorder? Medication-assisted treatment, that is things like methadone and Suboxone. And I think historically, recovery housing, a lot of recovery housing has been hesitant around accepting individuals on methadone and Suboxone because what methadone is, it's an opiate, and Suboxone is a partial agonist. So the fear is around diversion, whether someone could misuse their medication or other residents steal their medication. But I think that it's really important for us to take a look at how do we operationalize, how do we create recovery housing that can support an individual who is on methadone or Suboxone and make it safe for them and safe for the residents. And that's the productive conversations that I've been trying to engage in. And I think we're seeing more and more recovery housing that is designed specifically for individuals on MAT, and I hope that trend continues.
And John, if I could just piggyback a little bit off of Jason, and I think when we talk about MAT, medication-assisted treatment, when you hear treatment, you're automatically thinking about clinical opposed to the recovery community. And when we're talking about recovery, we're enhancing the quality skills of peers to become leaders, and we don't want to put them at risk in our community. I truly believe that it can happen, but I think that there's going to have to be a clinical set-aside to support the recovery housing model.
Interesting. Thank you, Trina. Sharon, any thoughts?
Yeah, I mean, I think Jason and Trina said it. It's interesting. We are having a lot of dialogue here at CCC because we're also a federally qualified healthcare clinic who is now providing Suboxone as part of our treatment models. And, I think Jason talked about it, the concern, especially around, I talked about the robust recovery staff that we have here, and a lot of it is around kind of education and kind of opening people's mind, and we are having a great dialogue around, you know, we allow MAT in the majority of our housing, including the majority of our recovery housing, and then we also have some set-aside units where, you know, it's that traditional abstinence space, so that, again, it's that choice. But we're not necessarily setting aside, like, specific houses or housing for MAT. We're trying to integrate it into the larger recovery community in a safe manner. But like Trina said, we do have that clinical staff and the doctors on staff that kind of help support the people working in the housing as well, which makes it good.
Great, thank you. Melissa, would you like to bring up a separate questions area? While I'm going to take the opportunity to remind everyone, please feel free to ask questions. We have a real brains trust here. They'll be here for another 30 minutes. This is your opportunity to ask any questions you have related to recovery housing. So I would encourage you to think of the things that you have a burning desire to know, and just put them in the question box. So we had one, and Sharon, if you'd like to take the first stab at this. One person has asked about examples of states or communities that have leveraged funding from either HRSA or HUD to build recovery housing that is also housing first in nature. How does that work?
So I'm not sure about the building recovery housing. So we have some really long-term HUD continuum of care funding that's helping support 3 of our recovery housing sites that we've also been able to leverage over time because that funding has remained flat for the last 25, 30 years. We've been able to leverage both state and county funding from the addictions and mental health side of the county. And so, you know, it is challenging in this arena because most of the HUD funding coming out, the bonus projects really are around housing first and harm reduction. We've done a lot of advocacy both here at the, you know, local level and the national level around, again, that need for choice. And I'm not sure if people have read it or if we could cite it someplace, but there was a recovery brief that had put out, I think, almost 2 years ago, based on a lot of work and interviews they did with Central City Concern and other places across the nation. And, you know, it's really about being at the table here for a local continuum and really recognizing that, you know, one size is not going to, you know, we're in a crisis here in Portland and probably across the nation, and we need to be able to have options for you know, different people and what their needs are. And while we recognize that our recovery housing isn't traditionally housing first, what we try to say also, though, is that our recovery housing, we require very little, like, recovery time ahead of time. So people are coming directly out of detox services, very low barrier in the sense that we are not doing credit checks, we're not doing criminal background checks. So all things kind of being equal, yes, we are asking people to move along in their recovery path, and then we intervene if they have relapses. It's not necessarily zero tolerance. And so by us kind of changing that look, we've been able to make some headway both locally and nationally, because we used to operate a lot of our housing as sort of the zero tolerance, you drink, you use, you go. And we knew, like, that wasn't working. We were just sending people back out onto the street. And so, you know, it is definitely a challenge, but I think that it can be overcome for sure. So,
I mean, it does sound as though there's some real housing first elements in there, if not a pure housing first model. Trina, Jason, have you come across this, and have you managed to pull any of those elements into your recovery housing? Tell me how recovery and Housing First kind of interact in your project or community.
Well, what I posted in the chat room is a link to HUD's brief on recovery housing that talked a little bit about that. And HUD's position is that recovery housing is not necessarily diametrically opposed to the Housing First philosophy. Housing First is about low barriers, not no barriers, and it's about supporting housing choice. And so to the extent that an individual who is choosing abstinence as their pathway to recovery wants to choose abstinence-focused recovery housing, then we should make that available to them, and that's completely in alignment with Housing First philosophy.
Great.
And I think for us, we have the 4 levels or 4 tiers that Jason explained about in his PowerPoint. Although our priority is co-occurring, meaning that you have an addiction and a mental illness, and so we're capable of serving you. And so one of the things that we see that's happening is that people come into the program and there's this gap in services where they want choice. And we've come to a point where we're looking at there's a HUD criteria that states if you accept these funds, then you're opening the door to Housing First, and it may not be just housing choice. So I think what we do as Mending Hearts, we look at female. We have a female-only campus, and so it wouldn't be right for us to accept certain funds from HUD that allow any caliber of person to come in under housing choice, that when we serve only women. So those are just some of the barriers that we face when we're looking at choice and Housing First. But when it comes to the caliber of the individual looking to abstain in recovery, then we have a criteria, and we accept women from 18 to 65. What we are seeing is the epidemic of more young adults than we are our older generation come through needing recovery and Housing First.
Great. Thank you, Trina. Let's take some of the questions from the presenter, the question box that are coming through. Going back to some of the questions we talked about earlier, self-governing housing, if there are interpersonal conflicts, who decides how you resolve these issues? You know, there's use or fights or ultimately a difficulty in personality. You know, who calls the landlord? Who calls the police? Well, how does that get resolved?
I'm looking at Trina and Sharon to see if they want to. Conflicts happen, and so a big part of learning to live life in recovery is learning how to, in a healthy way, resolve conflict. And within recovery housing, there is a set of house rules or social covenants. We all agree to live by certain parameters. But then there are, so if somebody is not adhering to the house rules, then it's really the entire community is empowered to hold each other accountable. But oftentimes there are conflicts that really kind of go beyond the house rules, and it's just a great opportunity to develop a skill set and utilizing senior residents. In the case of you know, the Oxford House, where they elect officers, the officers may have certain roles around that. In the higher levels of support, you have a designated house manager, and in even higher than that levels than that, you oftentimes see alumni really participating with the community, but it's you really undermine the social model philosophy if you come in there as a dictator and start kind of robbing individuals of the opportunity to learn from conflict and learn how to play nice with each other and support each other.
Mm-hmm. Mm-hmm.
And I would just add to Jason that, one of the things I think for us in recovery is that, we usually use it in a clinical setting, but it has worked across the board for our team, is that everyone is trained on de-escalation in crisis situations and having that protocol and procedure. If this happens, then we take these steps. But the other thing is to have the participant, sign on intake. If I break these rules, then I am positioned for discharge. The other thing that we've done in our community is that we have a no trespassing waiver with our county police, and we have to put every address listed, and if we have a conflict, we can call them for resolution to assist if it gets to that point.
Great. Thank you. So let's move on, and a couple of people, Jamie and Abigail, have said, we've got no recovery housing. Who's going to come in and help us build some? So let's talk about how do you start a recovery housing project? Anyone can take that.
You want to go, Jason?
Sure. I mean, I'm just thinking back to when I first opened up my recovery home, and trying to find a mentor. I mean, what historically what has happened is you either came up through a recovery home, that was part of your process, and so you end up opening your own under the mentorship of maybe the previous house manager, or the previous owner-operator. But one of the things that we're really trying to do now, whether that be the National Alliance for Recovery Residences or my organization in Texas, Recovery People, is developing some trainings and developing some TA resources so that we can help more individuals open quality recovery housing. You tend to see recovery housing in areas where there are already good recovery homes, and so that's fantastic. There still needs to be more in those urban settings, but there are underserved areas that I think that we need to be able to train people on best practices so that they can successfully open and sustain recovery homes in their areas.
And I think the other thing too is that we have to remember that there is no startup funding when we think about opening most recovery homes, and so it really comes from the passion and being driven by the mission of like helping people, and so it's not always easy getting started, and starting small is the best practice. I believe that helping people is a free will, and so if you can connect, like Jason said, with a mentor who has already done the front end, it's almost like don't create the wheel, you just copy and paste. It's make sure that you're following the guidelines and codes of your city when you're talking about recovery housing. And in best practice, we're mostly dealing with adults and even young adults. We have to make sure that we're not packing the house for funding, but really making it a comfortable setting so that people can enjoy an environment and not an institution.
Great, thank you.
One thing I'll jump in, and I can provide the link here in a minute. The National Alliance for Recovery Residences set standards, the kind of best practice standards for different types of recovery residences, and the way that it's written could potentially provide a blueprint for individuals kind of thinking about, so what are the types of policies and procedures, what are the types of things that we should be looking at if we're going to open up our own recovery home. And the first question I always ask people when they come to me for help is, so what population are you passionate about? Because this is going to be challenging, and if you're not passionate about a particular population, whether that be women and children, or LGBT, or individuals with a history of homelessness, then your light can burn out before you actually get to sustainability. So I am always encouraged when people are interested in recovery housing, but we definitely want to let them know that this is a process, and it can be done, but make sure that you do your research ahead of time.
Thanks. Sharon, one question for you. How do you track metrics, data, outcomes associated with the recovery housing that you work with? And have you ever used this as part of your fundraising or coverage? We had a question from Jeremy, and so perhaps you can touch on how you track your success.
Yeah, absolutely. I mean, I talked earlier that we have a lot of HUD funding and a lot of different government funding, so we're required to report on our outcomes. We locally are using the Homeless Management Information System to track all of our housing outcomes. We are actually right now in the process of acquiring a new software system for CCC that will kind of speak to our local HMIS provider so that we can kind of do more service tracking. But, we're able to, track, the number of people we're serving, the number of people, exiting to other permanent housing, income attainment, treatment completions. We're also, like I said, a healthcare entity, so we just created, have been working on this data warehouse where we can really see, 15 people went through our detox services. Of those people, 9 of them went to our recovery housing, and of those people, X completed the treatment. And we were just looking recently and saw that, which isn't really surprising to me, or probably to a lot of you, is that the treatment outcomes for those people engaged in recovery housing is like 10 times more successful than those people just entering treatment without any kind of recovery support. And that's just sort of some initial findings within our own data set, but it's really extraordinary, along with some really severe differences in healthcare costs for those that are entering recovery housing. So it's absolutely necessary to have data and be able to report outcomes, especially when we talk around sort of this challenge around kind of different kind of housing types and what will be funded, and especially in the kind of world we're seeing right now around potential budget cuts. And so it's really, really important that we continue to be able to show how well this recovery housing works. And so we've been using HMIS for a good 15 years now to track our outcomes in recovery housing and the rest of our housing.
Great. Have either Trina or Jason, have you had success with data use and showing the outcomes of your projects?
I think that the challenge or the opportunity, let's flip it to be strength-based. The opportunity is that we would find more funding to do research. The research that we do have, kind of building on what Sharon said, really shows that individuals living in recovery housing, there seems to be, like if they can stay 6 months, that seems to be a tipping point, and they develop more what's called self-efficacy. But, we really could utilize more funding so that we can research recovery housing and the different types of recovery housing. I know that providers, that because government dollars are oftentimes not available to recovery housing, and that third-party funding is generally what requires evaluation. That many providers that are just on a self-pay basis, they're using every penny they can to pay utilities and fix toilets, and so research is not on their minds just because they're so focused on sustainability.
Sure. So let's move on. Angela's asked a couple of questions about insurance. Insurance carriers approve and reimburse for recovery housing if the house is level 3 or 4. Can anyone elaborate on how that happens? What insurance companies do accept it? What are the criteria? Just give us a general overview.
So,
go ahead, Jim.
Sorry, I'm the loud one, so you have to shut me up sometimes. But the recovery housing that I know that's able to access insurance typically is the higher levels of support. So you have to realize that it's the states that determine what is licensed treatment, and so oftentimes the recovery housing that is licensed treatment in that particular state oftentimes can utilize the same insurance or bill insurance the same way that other treatment models can bill. Now, the exception to that we're seeing is like in California, where they're using their Medicaid 1115 waivers, and the 1115 waivers are meant to be very entrepreneurial. And so California has chosen to use some of that money to pay for sober living environments or level 2 recovery residences because of some of the stuff that Sharon was pointing out earlier, because you see real recovery outcomes if people are living in recovery housing.
And I think, for Mending Hearts, what we see is that the recovery housing piece comes in, and what we are licensed here in the state of Tennessee and how we incorporate insurance with housing is that we use what we call a day program or outpatient component to enhance the housing. And so that's a billable service. And while you get paid for the clinical piece on the front end for the service of the day in the outpatient service, then there's another housing piece. But again, there's a supervision in that housing piece that they want to see a staff around the clock 24/7. So it's a little different than your normal recovery home, because your normal recovery home, the peers, they go to sleep at the same time that their other peers do, but this person must be an awake staff in this part of the recovery home when you're dealing with the insurance.
Thanks, Trina.
Yeah, I don't really have a lot to add to that. We're not actually billing for services because we are a federally qualified health clinic. We actually get some wraparound money due to that. So if we billed, it would actually kind of take away from that. But I do want to just note, we've done a lot of partnering with the health systems here in Portland. And again, it goes back to sort of that data and being able to show the impact of housing in general and recovery housing on people's real, true kind of physical and mental health outcomes. And we just recently received a $20 million investment to actually build more housing, which will entail, another 130 units of recovery housing and then some more kind of low barrier housing. And so it's kind of a different way around, getting some of the health systems to invest in this housing, not necessarily billing for the services, though.
Good. Okay. Going back to some points that we made earlier, Abigail asks, how would someone find out? I may be interested in referring someone. I may be interested in building one. How do I find recovery housing in my county, region, area?
I would think that Jason talked a lot about NAR. NAR is opening its scope of services around a variety of states, and I would really look there, but also I'd look at my state because in the parole and probation, they have a list of certified recovery housing for people who are in reentry or probation or parole. But I think NAR will give most states and I'm not sure how many are affiliates at this time, but you can usually go on there and kind of connect links with different states to find out who has housing in your state. Jason may want to piggyback off of that.
That you were reading my mind, Trina. That's exactly what I was going to say. Is NAR is in 20 different states. We have state affiliates, and it's those state affiliates' responsibility to certify recovery houses that meet the national standard in that particular area. So if you go, it's naronline.org is NAR's website, and from there you can drill down into the respective states. And Raymond asked, is there NAR in Georgia? Yes, actually, GAR, G-A-R, the Georgia Association of Recovery Residences, that has been in existence probably 30 years. It predates NAR, and they have, I believe, a roster of recovery residences there.
Great. Thank you, guys. We've got time for 1 to 2 more questions, and I think we're going to put up some pods for downloading today's presentation. But Jonathan, and I want each of you to answer, but try and keep it to a minute. How do you define success? Sharon?
I talked a little bit about the funding, so a lot of our success defined by funders is around kind of that permanent housing placement, exiting our housing, or housing retention, people staying in recovery and in that housing for at least 12 months. But for us also, I mean, we're looking at, completion of treatment. We're looking at, different life skills, income attainment. One of our programs looks at, it's very 12-step focused, where it's like, do you have a home group? Do you have a support person? Do you have a service position? I mean, it's really this wide array of things because it's people's personal journey. So sometimes it's hard to define success. It looks different for other people. But I would definitely say that, that housing retention and recovery, people staying in recovery for longer amounts of time is definitely one of the biggest markers we look at.
Trina, I think you might be on mute again.
I'm sorry, you can't hear me. Yeah, but I like to join Sharon in saying, I think when you look at Maslow's hierarchy of needs, that is a primary focus that I think what you look at success at in the beginning, because it's not a cookie-cutter process when you look for recovery. The primary goal is to get clean and stay abstinent, but there are a variety of different needs when you meet that participant, and everybody don't go to the same grocery store to get the same product. And so I think you have to be open-minded when you're looking at success for your particular program. And being that we have 4 levels of care, success doesn't look the same for all of our 90 people. And so, we want to make sure that we bring them in and get them stable and find out what those needs are. Some are vital records. Some is, hey, I need to get my medical taken care of before I can fully recover. And so I think it depends on the agency and the participant themselves.
Right. Jason, last word?
Yeah, success is, recovery, and recovery is nonlinear. And so just because someone may have their symptoms may exacerbate and they return to use for a short period of time, I don't, sobriety is an easy thing to measure, but I don't think that's what we completely hang our hat on. I think that we need to be looking at recovery outcomes like, kind of going back to the 4 supportive dimensions at the beginning. Are individuals being able to, have purpose? Are they employed? Or, what's their monthly income? What's their quality of life? The World Health Organization has a quality of life metric that I really support us using. The recovery capital scale, looking at, where are they at from kind of building their internal and external assets. And then I think, also picking up some metrics like recidivism and hospitalization. That's going to be some indicators of recovery outcomes, but it's also really important for us to be able to show our potential funding partners that we are an important resource that can support them and their own goals.
All right, some very interesting points. I want to thank our three awesome presenters, Trina, Sharon, Jason, and you for attending. We're glad so many of you could come today. Before we finish, I want to remind you that you can join Brass Tack's mailing list. There's a web link pod at the top. I know some of you may have